Welcome friends, this is Dr. Jaitly, your cardiologist on your favorite video site, MuniMeterHealth, which is being shown on several social platforms media. So welcome again on MuniMeterHealth. It's a learning channel primarily for cardiology and for human heart, where we improve the medical education as well as the patient education, as you see, and this is only in order to improve the clinical outcomes, which has been clearly shown. And my deepest belief is that if you combine the two, the medical and the patient education, both to medical fraternity as well as to the patients, the clinical results are amazing. So without any further ado, I'd like to delve into the subject matter. Today is purely a diagnostic, and an informational channel video vignette I'm presenting. This is myocardial viability. What is myocardial viability? Well, myocardial viability is an intriguing subject in where the myocardium, the myocardial cells, which have been deemed to have chronically low flow state, are still viable, and they can restore their fullest function once the circulation is reestablished. So there were two terms that were coined, one by Dr. Braunwald and the other one by Dr. Broley. Hibernating myocardium in early 1980s or mid 80s, that's when the concept of hibernating myocardium was evolved, where a low flow state was ascertained in a setting like something like chronic ischemia or a chronic ischemic heart failure state, where there was a reduced functional state, but at the same time, if the functional state could be compromised because of the low flow state, all you had to do was reverse the low flow state and you will have a complete restoration of function when blood flow is restored. Now look at here, this is an example. Here you have hibernating myocardium, where the flow tends to go lessen and lessen and lessen and lessen over a period of time, say maybe several days, several weeks, several months sometimes, or even years. Like in chronic heart failure state, it could actually be hibernating for a long time, and it only gets worse over the next several duration of time. So now the gradual reduction on flow is also accompanied by a gradual reduction of function. So the segments in the left ventricle, specifically we are talking about the booster chamber, that also gets compromised. Now and then over a period of time it becomes more sustained in as far as temporal relationships are concerned with the time. And then if you were to restore the coronary blood flow, as soon as you ascertain that this was the myocardial segment which acquired the chronic ischemic state to be reversed, as soon as you reverse that over a period of time, gradually you will see that the functional state will also return back to normal. So that was the hibernation theory and hypothesis, and that is still in vogue right now, and people have started to look at it very differently through our diagnostic imaging, as we're going to just show you in a second. The stunning was that was a classic chronic ischemia state. Now stunning implies where there is an abrupt loss of blood supply to the region, and so that is the classic example is obviously acute myocardial infarction, so where there is a total or near total occlusion of the vessel. So here you have the blood flow, folks, and then it abruptly stops. So obviously the blood flow just declines, and then it stays in for several hours. This is only in hours, and then following that, obviously the function has deteriorated rather quickly also at the same time. So you'll see the function has declined. But then as soon as a restoration of the blood flow, like say an open PCI or a primary PCI or an angioplasty is performed, the arterial supply to the coronary, to that segment, is restored. And as soon as that gets restored, say over the next several hours, it takes only days and weeks for the segment to return back to normal. So within a matter of say 4 to 6 weeks, the function will return back to normal, provided it is salvaged within 4 hours. So here the time is very crucial in the stunning part. Plus also just remember that there is an abrupt reduction in the function and the flow as a result of near total occlusion. Hibernation, on the contrary, differs a little bit in that there is a gradual reduction in flow and functional state over the several months, sometimes even years, as you see here. And then when you restore the flow, also it returns back to normal, but takes longer period of time for it to return to normal. Okay, now let's see how do we diagnose hibernation and stunned myocardium, or myocardial viability rather, through very simple protocols that have been evolved in nuclear cardiology. Now, Thallium 201, which has been practiced since 1970s, has been a great isotope, which really banks upon two things. One, it uses the sodium-potassium ATPase. So, in other words, it'll require the membrane viability of the myocardial cell in order to show the regional perfusion. So you inject the Thallium 201, say, at rest, and then take pictures. And once you complete the imaging here, what happens next is you can take the second set of imaging in 4 hours. And when you repeat that in 4 hours without any re-injection at all, now what happens is over a period of time, 4 hours, you will see that segment would have returned back to normal. Now, say for instance that there was say an apical wall defect, for instance. Here we're going to draw the hypothetically theoretically an apical wall defect here. So this was at rest, for instance. Now during stress, what happens is all of this shall return back to normal. Not stress, but in the second imaging rather. So this is the first imaging, and this is at 4-hour imaging, and that is called the redistribution. That means the redistribution occurred because it took a little longer time for the myocardial cells to do the uptake of thallium, because remember, thallium is being uptaken actively through the sodium-potassium ATPase, except that the myocardium here was very active, here was very active, here was very active, here was very active, but here it was hypoactive, but it was alive. The very fact that it's viable, it's going to take a little longer, but in 4 hours you could see it. Now, a lot of people have suggested that sometimes you may not see the entire segment being visualized in 4 hours as a viable segment. It could have been, say, only partial segment viability was seen at 4 hours. Then evolved the second protocol where they started to image patients for 24 hours. So this became the rest redistribution delayed imaging. Likewise, the same was true with the stress. So what they did was the thallium is injected at the peak of the stress when the patient is exercising, and say there are segments which are totally normal except this segment, and then it redistributes. Then of course that gives you the idea that this is an ischemia anyway. So here the third protocol where I showed the resting thallium imaging at done at and then at 4 hours, and then repeating it at 24 hours, that showed the rest redistribution delayed images here in this fashion, and was able to even ascertain even more segments, approximately even 60 to 70% of the segments that were not seen at the 4-hour imaging. So 24-hour was a better yield, as you see. So without any reinjection, and you just have to bring the patient back in for the next day and do the 24-hour imaging, and it takes about 15 minutes to complete that the next day. And guess what? You learned a great deal, because there were more amount of viability segments that were actually seen in that individual. And similarly, there came the fourth protocol. Then they said sometimes the thallium is not enough to really persisting, because obviously thallium has its own half-life, so it is decaying constantly, and because it is decaying, there's a chance that some of the thallium would not have gone back in because there was not thallium enough to begin with. So there came the philosophy or the hypothesis where actually do a 4-hour re-injection of a small amount of thallium at that point. So the resting images were just the same. You did a 4-hour imaging, and then at that point, after the 4-hour imaging, you did a small little bit of re-injection, which is of a smaller amount of thallium than the previous thallium. This was only to combat that hypothesis that the thallium which was decaying now was reinforced here to ascertain the rest of the segments which were being viably seen at 24-hour period. So the 24-hour period of the imaging was still persisting, and you found that even the yield was even bigger, because now you saw more viable segments that had returned back to normalcy. So in a nutshell, myocardial viability is a huge subject. Today you want to open an artery provided there is myocardial segment that's alive. There's no point in opening an artery and going after an artery when actually you don't have much viability. So the viability assessment is extremely crucial, especially in chronic ischemic states like in hibernating myocardium. And stunned myocardium, of course, people have been practicing for now almost 2-3 decades, where primary PCI is being performed rather quick. So as soon as within 4 hours, you can open up the artery, you will be able to restore the function of the myocardium to near normal or almost normal. Okay, but there are very good, I call them poor man's nuclear cardiology protocols, because now you have PET PET FTG, and you have cardiac MR, which is almost becoming the gold standard for myocardial viability, and then you have SPECT PET, which we'll be discussing at a later time. But just so that you know, the poor man's nuclear cardiology protocols are still Thallium 201, and they're prevalent in almost every institution now, and has been around for like 3 or 4 decades. So just so that you know, so there's a rest 4-hour redistribution protocol, there's a stress rest protocol, there's a rest 4-hour 24-hour protocol, and then there's a rest 4-hour reinjection delayed protocol. Okay, so these are the 4 protocols for Thallium, which I tried to summarize very quickly for you guys, especially if the residents and fellows, they're planning to take the boards, or even if they are going back and attending the tutorials, the classes the next day. This will be a good brush up. Again, it's not a substitute to your syllabus. Please remember that. This is only a supplement. And of course, as I said, this is purely an informational learning channel. It's not a treatment advice channel. Once again, stay well and stay on MuniMeterHealth. And until then, say goodbye to Dr. Jaitly, and see you again on my